Hi, everyone. Thank you for joining us today. We're going to give everyone just about one more minute to get started, but you are in the right place if you're here to learn about the latest on the hepatitis B vaccine recommendations. We're just going to remind folks to mute yourself if you're not speaking, and that way we can have our speakers and panelists have the full floor. So we're going to give folks about one more minute to get started, and then we will be on our way. So thanks, everyone, for joining us today.
Progress.
All right, so we're gonna get started. So thanks everyone for joining us. I see a lot of folks from Hawaii, but also from outside of Hawaii. So thanks for everyone who's joining us from the continent. Again, I want to remind folks where you are. So let me just start to share screen and welcome you to our space today. So today you are at a talk story session on hepatitis B vaccines. This is very important, of course, for all of our states and communities across the US, but also for Hawaii in particular, given our communities that we serve. So we're gonna have a quick session today, and hopefully you folks will get a lot out of it. So I'll start with myself. So I'm Thaddeus Pham, he, him. I'm the Viral Hepatitis Prevention Coordinator with the Department of Health. And I'm also the co-director of our community coalition, which is Hep Free Hawaii. I do want to thank everyone who was involved in making this happen. This is truly a community effort bringing this together. So I'm going to thank, of course, Department of Health, but also the University of Hawaii's Cancer Center, the Hawaiʻi Comprehensive Cancer Coalition, the Hawaiʻi Immunization Coalition, and then Dynavax Technologies as well. In addition, I want to give a special shout out to all of our speakers today. So Dr. Vivian Huang, Dr. Seiji Yamada, and Dr. Michael Haight, who have already started a robust discussion even before this session began, right before you all joined us today. So we're really excited. We hope that you will participate. And with that in mind, I encourage you to put comments and questions in the chat, which I'll monitor during the Q&A, so you can get your questions answered or just provide comments and ideas in terms of how we can make hepatitis B immunizations more impactful for our local communities. I just want to remind folks, if you are not speaking, to mute yourself so that we can ensure that everyone can hear everything very clearly. So what's going to happen today? I'll ask you folks right now if you could just introduce yourself in the chat. Just put your name, organization, pronouns, and anything relevant you'd like us to know so we can get to know who's on the line today with us. I'll provide some local context. I'll turn it over to Dr. Huang, who's going to talk about the new CDC recommendations. Then I'll open the floor for Drs. Yamada and Haight to give their perspectives on challenges and opportunities on these new recommendations for Hawaii. And then I'll open it to you folks for questions and answers. So let's get started. So we'll first give you a little context. I mentioned that I'm the co-director of Hep Free Hawaii, and we came up with, as a community, a 10-year elimination strategy entitled Hep Free 2030. So this is our local strategy to eliminate viral hepatitis in Hawaii. And as you can imagine, it's very complex. But what we try to do is ensure that we have certain directions that we're going in collectively. This is our mission and vision. I won't read this to you, but I'll just note that we're really values driven, as you can see here. And so the work that we do in hepatitis, including immunizations, is really driven by harm reduction, social justice, intersectionality, and aloha. And we always restate this at any of our meetings, just so that we are all on the same page in terms of our values. So we welcome you all in this space, and we are so honored that you folks can share these values with us as we move forward today. I mentioned that there's directions that we're heading in collectively. So this is our Hep Free 2030 wheel of priorities. I'm sorry it doesn't spin, but this is just give you a snapshot of what the community and the stakeholders in Hawaii specifically identify as important opportunities to eliminate hepatitis. So we talk about awareness and education, which is happening right now with all of you folks. Access to services, this is the clinical portion. So this is immunization, testing, linkage to care and treatment. advocacy at all levels. So this is both policy organizations, but also federal, national, and global policies, and local policies as well. Equity in everything we do, and also data for decision making. So in these priorities, I'll just note that immunizations is one of the specifically mentioned directions for access to services. So we're so excited to have this session today. This is a little bit more, it goes a little bit deeper. Again, I'm not going to read this to you. This is all available if you just go to hepfreehawaii.org. But just wanted to kind of show you some of the details in our statewide strategy and how this session and the work and the discussion we'll have aligns with our statewide strategy to eliminate hepatitis. I will also note, thanks to our friends from the Cancer Coalition and the Cancer Center in Hawaii, that as of the last plan that we had available, hepatitis B immunization was one of the specific objectives that they noted in their cancer strategy. So not only are we aligning with our hepatitis strategy, but also our statewide cancer strategy. So mahalo to all our cancer folks who are joining on the line as well. And before we go into some local context, I want to see what you folks know. I know some of you are from Hawaii, some of you are not, but I'll just do a quick poll for you to see what you folks think. So I'm going to share and launch a poll. Let's see. The first one is just about the recommendations that we'll talk about today. So the question is, for those of you who are just on the phone, all adults aged 19 to 59 are recommended to get the hepatitis B vaccine. True or false? I'm going to give you folks a few seconds to answer this. Hopefully, you folks are already aware of this as you're joining us, but we'll give you a few more seconds to answer this question. And it looks like we'll got quite a few responses. So thank you everyone who responded. And I'm going to share the results here with you. So congratulations, correct, true. And Vivian, Dr. Huang was going to talk about this more today. So there is a new recommendation for all adults aged 19 to 59 to get that hepatitis B vaccine. And so the next question I'm going to ask you is about Hawaii itself. So there's a 2-question poll here. And if you folks can answer this. The first question for those of you who are just listening in is, Hawaii has higher rates of liver cancer incidence and mortality than the general US. And the second question is, hepatitis B is one of the leading causes of liver cancer in Hawaii. So if we could have folks just participate in that. I see a lot of folks chiming in already. We'll give you folks a little bit more time to answer. And I'll end the poll in about 2 more seconds. Anyone last comments or last poll taking? And here are the results here. So I will give you the answers coming up, but it looks like most of you put that Hawaii has higher rates of liver cancer than the general US, and that hepatitis B is one of the leading causes. So thanks everyone for participating and sharing a little bit of what your thoughts are. And I'll go ahead and tell you what we know in Hawaii. So in terms of local context, this is the answers to the questions you just took, but according to local data, hepatitis B and C account for most of the cancer cases in Hawaii, according to our transplant center, and that Hawaii has higher rates of liver cancer incidence and mortality compared to the general US. We actually used to be the state with the highest rate of liver cancer, but other states have now surpassed us in terms of that. So hopefully that means we're doing well rather than they're not doing as well. These are just some of the communities affected by viral hepatitis, especially vaccine-preventable hepatitis in Hawaii. You'll note that hepatitis A especially affects houseless people, and Hawaii does have the highest per capita rate of houseless people in the US as a state. Viral hepatitis also affects people who are sexual gender minorities, so those are usually what we think of as LGBTQIA+. And of course, our folks who are born in Asia Pacific are also disparately affected by hepatitis B. So these are many of the communities that we work with locally, and that's why this is so important, because it affects so many of the people and communities we work with. Finally, before I head into Dr. Huang's presentation, just wanted to note the data that I pulled from our Hawaii Health Data Warehouse. This is from the BRFIS survey, so it's the adult survey on completing hepatitis B vaccine. So this is self-reported, it's a phone survey. But if you note, overall, if you look at the bottom, about 58% of adults reported that they had completed the hepatitis B vaccine series. So where it's pretty good, it's over half. There's a lot more work to be done, and I think you folks are part of the great work that can help us increase immunization rates for hepatitis B among adults in Hawaii. So I shared a lot of information with you folks. This will be shared with you later, but now I'm going to turn it over to Dr. Huang. So I'm going to stop sharing and provide opportunity for Dr. Huang to share a little bit about the new recommendations. So Vivian, do you want to go ahead and share screen?
Hey there, everybody. Able to hear me okay?
Yep.
Great. So good afternoon, everybody. And Thaddeus, thank you for that. I am really excited and honored to be back here again to talk about the new and expanded CDC ACIP recommendations for adult Hep B vaccinations. And from the poll there, I think everybody knows that this is now a universal vaccination recommendation and such a landmark decision from CDC ACIP. I think this has been a long time coming for all of us, and so very excited to be able to come present to you all. My presentation today will be mainly to highlight some of the important areas noted in the new recommendations, and so the next couple of slides in my presentation will be about that. And so once again, my name is Vivian Huang. I am currently the Regional Medical Director for the West region in the Medical Affairs Unit here at Dynavax, and I live in Phoenix, Arizona. And today I have a few objectives that I'd like to discuss. So first, I will briefly review the new recommendations, and then next, I'll provide some of the main highlights of these new recommendations. My presentation will be about 15 to 20 minutes, and then we'll open it up for discussion with Dr. Seiji and Dr. Michael. So first here, let me try to see if I can find my pointer. Let's see here. Here we go. Okay, so in our talk story number 1, which happened back in March, I was able to review the new recommendations. But if you missed it, I'll just briefly refresh everyone here again on the new recent, new expanded recommendations. So what do the new expanded adult Hep B vaccination recommendations look like? Well, for one, it's definitely more simple and easy. And so the first thing we'll do here is just look at the left side of this slide, and you'll see here on the left side of this slide, it's pretty busy. There's a lot of words here. There's 15 or more recommendations. And so one of the main challenges with this risk-based recommendation was really challenging to actually identify those persons that had risk factors. So for example, if you're a busy provider, very hard to remember all these different risk-based recommendations. The other thing to note here is that some of these risk factors are stigmatizing and can actually criminalize some patients. So often patients would feel really uncomfortable disclosing these types of risk factors to their provider. So the CDC recognized that these recommendations were challenging, and certainly it has helped in the past, but it's really it left something to be desired. So what has happened is the CDC has now voted for new recommendations. And so you'll see that the new recommendations here are actually on the right side of this slide. And you'll see that the recommendations are in yellow here and highlighted in this box. And so these recommendations really simplify and streamline the old risk-based strategy. And so what do these new recommendations look like? So the first one is here you'll see that all unvaccinated adults aged 19 to 59 years should now receive Hep B vaccination. And so this is really considered a universal vaccination program where all adults previously unvaccinated for Hep B should now receive Hep B vaccination. Now, the last two bullets here are actually for adults aged 60 years of age and older, and it's a little bit more complicated for these folks, but you'll see that there's some expanded access pieces here. So the first one we'll look at is the second yellow bullet here, and these are for adults aged 60 and older who have been unvaccinated and have risk factors for Hep B should receive a Hep B vaccination. And so we haven't done away completely with the risk-based recommendations, and those still remain for those folks 60 years and older with risk factors. The other piece here is the third bullet here, and then you'll see that in this last bullet, unvaccinated adults aged 60 and older without known risk factors for Hep B may now receive a Hep B vaccination series. So these recommendations are really an expanded universal vaccination program. And this was actually passed with a unanimous vote of 15-0, which was last year in November, and this was passed by the ACIP. And then these three new expanded adult vaccination recommendations were included in the 2022 ACIP adult immunization schedule and was actually included in the MMWR that was published just last month. And so just to summarize here, again, these recommendations are just these three highlighted in yellow. So all unvaccinated adults aged 19 to 59 years should receive Hep B vaccination. The second recommendation is unvaccinated adults aged 60 years with risk factors for Hep B should also receive Hep B vaccination. And then the last part of this recommendation is unvaccinated adults aged greater than 60 years of age without known risk factors for Hep B may receive Hep B vaccination. So now let's look at some of the main key takeaways of these new recommendations, and that's been actually outlined in the MMWR that was published last month. And this MMWR was dedicated specifically to look at these new recommendations, and they're broken down into a few sections. It's a pretty short read, it's about 5 pages. And in these next couple of slides, I'll just focus on some of the specific points that are of importance. So here, let's first look at some of the important information that was provided in the background section of this MMWR. So we know that in 2019, there were actually close to 3,200 cases of acute Hep B reported to the CDC. And so that corresponds to about 20,000 estimated acute infections. Now, one thing to note here is that when it comes to risk factor information, about 2/3 of the cases that were reported, we either did not identify a risk factor or the risk factor information was actually missing. So really, for the majority of patients that got infected, we actually don't know how they were infected. Now, of the risk factors that were reported, and this is only in 1/3 of the cases, we know that about 35% of those that got infected were from injection drug use, 23% from multiple sex partners, and 10% from surgery. Now, we also know that in 2018, hepatitis B vaccination coverage was only about 30% for adults aged 19 and older. So that's a pretty low number, and we certainly have more room for improvement. So probably right now, you're probably wondering why these new recommendations came about. And so I'll highlight just a few reasons here as to why these new recommendations were made. So first is that we know that close to 75% of acute Hep B cases occurred in persons aged 30 to 59 years in 2019. Now, unfortunately, we've also noted that in the reported cases for those adults aged 40 to 49, there's been an increase, and the incidence has increased from 1.9 per 100,000 in 2011 to 2.7 per 100,000 in 2009. And unfortunately, again, we know that in those persons aged 50 to 59, there's been a whopping increase of 46% of acute cases. And this is an increase from 1.1 to 1.6 per 100,000 for the same period of 2011 to 2019. Now, something that I did not know and worth mentioning here when I read the MMWR is that the rate of hepatitis B infection among non-Hispanic Black adults was 3 times as high as compared to that of Asian or Pacific Islander adults and twice that of Hispanic adults. So something to kind of think about when these universal recommendations were made to make sure that we cover all race and ethnic groups in the US. And then the last thing that really stood out for me in this particular section and really noteworthy is that when the universal vaccination strategy was implemented for children and teens back in the late 1990s and early 2000s, we did see a considerable decrease in the rates of hepatitis B infection in later years in these groups. And so I think with that as a caveat and also lessons learned from that and the successes from it, we are hoping that with these new universal recommendations, we will see a similar trend for adults, especially in those older age groups. So now this next section here provides the clinical guidance, and I'll just call out a few notable recommendations here. So in the MMWR and also obviously in these new recommendations, there's now some new language, which states that adults ages 60 or older without known risk factors may receive Hep B vaccinations, and this is part of the current recommendations. And this current recommendation actually is being replaced by what's crossed out here on the screen on the slide. And so the previous recommendation was all other persons seeking protection from hepatitis B infection may get the vaccine. And this new language was actually put in place to really shift the responsibility of bringing up vaccination recommendations from the patient to the provider. So instead of having the patient bring up that they need the vaccination, it is now on the onus of the provider to actually make this recommendation to their patients. Now, another thing to note here is, well, who should actually get vaccinated? And I think the MMWR does a good job to point this out, is that persons who have completed Hep B vaccination series at any point or who have a history of Hep B infection should not receive Hep B vaccination. So how are you going to figure this out? And so the MMWR actually puts this particular statement in, and it says that providers should only accept dated records as evidence of hepatitis B vaccination. So just if the patient only tells you by word of mouth, that's not sufficient. What the provider needs to do is to check for whether it's an electronic medical record, whether it's actually through the vaccine registries, or whether it's through school records. As long as it's dated, then this is sufficient to prove that the patient has had their Hep B vaccination series. So this next 2 slides here that I'm going to talk about are actually 2 common questions that come up pretty frequently. And so the first question here is, when do you actually screen for hepatitis B? And really, how does the screening for hepatitis B factor in with vaccinations? And I believe on our last talk story, Dr. Seiji brought this up. And I think this is actually a very important point, and especially for Hawaii, given the prevalence of hepatitis B here. So one thing I will point out is that in order to determine who does need to be screened for hepatitis B, what this recent MMWR, which was published last month, does is actually refer you back to actually an older MMWR, which was published in 2018 here. And the title for that MMWR is Prevention of Hep B Virus Infection in the US, Recommendations of the ACIP. So I've done a little bit of legwork here just so that we can quickly review these guidelines, and so you don't have to do the work here and you can actually just refer to these slides. One of the things that when you are testing for hepatitis B, make sure it's a trifecta of tests. So it's actually the hepatitis B surface antigen, the hepatitis B surface antibody, and then also the hepatitis B core antibody. And then, so who are you actually, who do you need to actually screen for hepatitis B? So here are actually the 4 buckets of people that you would actually screen for hepatitis B. So first is actually persons born in countries of high and intermediate hepatitis B prevalence. So in countries that have prevalence greater than or equal to 2%. The next group of people that you would screen would be US born persons not vaccinated as infants whose parents were born in countries with high hepatitis B prevalence. So for example, my parents actually came from Taiwan. And so that is actually a country that has higher hepatitis B prevalence. And so I would have needed to be screened. So that would be an example of who would be screened for this group. Now, the third group of people would be persons needing immunosuppressive therapy, including chemotherapy, immunosuppression related to organ transplantation, and immunosuppression for rheumatologic or gastroenterologic disorders. And then the last group of people that really need to be screened for hepatitis B include donors of blood, plasma, organs, tissues, or semen. So I think a very important point that needs to be brought up here and just highlighted is that screening should actually happen at the same time with vaccination. So if you've got your patient in the office, what needs to happen is if you're going to actually screen and they fall within these 4 buckets, these 4 groups of people, then you draw the blood first and then you vaccinate. And this should all ideally be done at the same visit. Testing is not a requirement for vaccination as per this MMWR. Now, this second question here is also a very frequent question that comes up when we're discussing these new recommendations. And so again, who should get post-vaccination titers? When should you check for titers? And again, the groups of people that are actually outlined to get titers actually go back again to this original MMWR, which was actually published in 2018. And it's the same one as what I just mentioned in the last slide. And so I think the first important point to remember is that most patients actually don't need to get titers. So if your patient is generally immunocompetent, meaning generally healthy, you really don't have to check titers on them. And I know that that sometimes isn't as easy to follow, as the titers are simple enough to get. However, just want to remind everybody here that titers aren't necessary for the generally healthy individual. And so here I've put for you on this slide are the following persons where titers should be checked. And there are many folks on here that are healthcare providers. So that is one group of people that is recommended to get their titers. Another group of people includes public safety workers, also hemodialysis patients, HIV infected persons. And then another group here includes those people that are immunocompromised, including patients who are getting a stem cell transplant or persons receiving chemotherapy. And then the last group here would be sex partners of hepatitis B positive persons. And so one thing to remember is that while it's really easy to order a titer for patients, once you have that result, you have to actually do something about it. So it's just something to think about when you are considering getting titers for patients. And the last slide here that I will talk about is these special populations that were mentioned actually in the MMWR. And so the first group of people that are mentioned is hemodialysis patients. And as of now, the safety and effectiveness of Heplisav and Prehebrio have not been established in adults on dialysis. If you look at the MMWR, there is a table showing the dosage and schedule recommendation for Endrix and Recombivax for dialysis patients. Now, there have been 2 studies that have been published looking at the Hep B CpG vaccine, also known as Heplisav, use in hemodialysis patients. So if there's anybody on this call that's actually interested in this topic, please feel free to reach out to me and I can provide you with further information on that. Now, the second group of people that the MMWR mentions are those that are breastfeeding. And so just want to share here that data are not available to assess the effects of Heplisav and Prehebrio on breastfed infants or on milk production and excretion. But with that said, I will say that the CDC has stated on their website that recombinant hepatitis B vaccines are safe for use in lactation. And then the last group that they mention are those pregnant women. And so regarding pregnancy, again, data on Heplisav and PreHevbrio are currently insufficient to inform vaccine-associated risks in pregnancy. But with that said, pregnant women that need Hep B vaccines are recommended to get Engerix, Recombavax, or Twinrix. But I will just note here that pregnancy is not a contraindication per the Heplisav package insert. For this population, there has been a recent publication looking at women that got pregnant in head-to-head pivotal trials comparing Engerix to Heplisav. And so if there's any interest again in this topic, please feel free to reach out to me to discuss further. That was a short and brief presentation, and this concludes what I have to say about the MMWR. I appreciate everybody listening in. Thank you for being part of this. I hope that this presentation was helpful to all of you. I know it was a lot of information, so please feel free to reach out to me. My email is actually on this slide. And with that, I will turn it back over to Thaddeus.
Awesome. Thank you so much, Dr. Huang. And you're already getting some questions and comments in the chat. So I'm going to actually ask some of them right now because they were responding to what you had just presented, and then we'll open it up for Drs. Haight and Dr. Yamada. So Dr. Saltman, who I know personally and is from Hawaii, he said, thank you for saying to vaccinate just after drawing blood for the screening. Also included would be those folks being screened and or starting treatment for hepatitis C, not immunosuppressive per se. And so Dr. Haight just agreed with that regarding screening for all patients for Hep B before starting Hep C treatment. Did you want to make any comments to that or anything?
I don't have any comments regarding that. I think, thank you for highlighting that.
Awesome.
Per the AALSD recommendations on treatment for Hep C is that you have to know Hep B status and treat it prior to treating Hep C.
Awesome. Thanks, Dr. Haight. And another question came in from Rensley. Is it only for hemodialysis, or what about peritoneal dialysis?
Right now for dialysis patients in both groups, there is no safety or and effectiveness data for PreHevbrio and Heplisav. So the recommendations are to use Engerix and Recombavax.
And one question came in through just a private chat. So if there are non-seroconverters for Hep B, is there any new recommendations? And then they added, they're supposed to check the titer, then get another series not to exceed 6 doses. And if they still test negative, they're just to check with MD.
Yeah, so it depends on what you consider non-responders. Usually what we say is that after 2 series is considered non-responders. If you actually do 1 series, and for the folks on the line here, there's actually also a 2-dose option. And if you need to check the titers, it's usually 1 to 2 months after the series is given. Now, if it's insufficient, you would repeat a 2nd series. And so if you have the 2nd series and they are still non-responders, and at that point, they're considered true non-responders. We have had some situations, there's actually a study looking at HIV patients who we know generally do not respond as well to Hep B vaccines. And when given Heplisav, we have seen favorable outcomes in that. But if whoever asked that question, if there's more interest in that, I can certainly reach out. Who is that person actually that asked that question?
It came through a private chat, so what I'll do is I'll put your email in the chat for anyone who wants to follow up. And And folks also have an opportunity to ask questions during Q&A. But for now, we'll turn it over and we'll ask a couple broad questions based on what you've shared with us, Dr. Huang, to Dr. Michael Haight and to Dr. Seiji Yamada, who's going to provide some local perspectives. So first, I'll just ask Dr. Yamada, just to, if you don't mind, just giving a brief introduction on yourself and your role and your kind of interest in Hep B. So I'll start with you, Dr. Yamada. Do you want to go ahead?
Yeah, hi. So I'm a family doc, and I would say that looking at these MMWR recommendations, they're really intended for the entire country, and of course we all know that we all practice locally, and whether it's medicine or public health, and I would say that I've had most of my clinical experience with hepatitis B patients at the Kalihi Palama Health Center, which is a federally qualified health center in Honolulu, with which I'm not associated now, but where I worked side by side with Dan Saltman, and after my departure, I think Victor Inada, also on this call, took over many of my Hep B patients. So I'd say working in a place where I was actually being referred the Hep B patients for monitoring and treatment, as well as treatment of pregnant women to decrease mother-to-child transmission. Just seeing that group of patient population, I feel that it really does behoove us in these high-risk populations not to just vaccinate kind of willy-nilly, but to make sure that you actually are not dealing with a patient who already has a hepatitis B infection, because that certainly changes things to recognize unrecognized hepatitis B infection, of which there's plenty, and I think I understand, from listening to a CDC presentation about this new MMWR new Acip recommendation, that perhaps later this year or next year that the CDC might come out with a more robust screening recommendations, and that would certainly be great. And when we're dealing like we do here in Hawaii or in parts of the continent where there's lots of Pacific Islanders and Asians, Asian Americans, but I think in particular Asian immigrants, as well as Pacific Islander immigrants, migrants and such. I think we do need to screen more robustly to try to catch these folks that have hepatitis B, and to do it sort of on a population basis, and not just send Hep B and C serologies on patients that happen to have elevated transaminases, which is of course a good excuse from the kind of getting it covered by insurance perspective, to be able to say transaminase elevation as your diagnosis for doing those sorts of tests, but to be able to screen people sort of population wide without regard to sort of clinical parameters.
Thanks,
Let's
Dr.
see.
Yamada.
So yeah.
Oh, go ahead. I just wanted to note really quickly, as you pointed out, I put a link in the chat for folks if you want to look at it. The CDC is seeking comment on updating the hepatitis B screening recommendations, and I believe they're accepting comments by June 3rd. So they're well on their way to kind of seeing updating that as well. And I just wanted to give an opportunity now for Dr. Michael Haight, if you don't mind just introducing yourself a little bit about your role in Hawaii and its relevance to hepatitis B, and then I'll go ahead and ask you both an additional kind of broader question.
Great,
so,
great. Yeah, I'm the medical director at Aloha Care, where I've been for the last 10, 12 months. I live on Kauai. I'm still faculty and actively practicing at UCSF in California, kind of go back and forth, but mainly doing telemedicine, and have a background as a pediatric gastroenterologist. So I've seen kids with liver disease. From a health plan perspective, I was able to survey the folks at Aloha Care, which is sort of in alignment with the general medical plans on mainland, and that all hepatitis vaccines should be covered without prior authorization. The key thing, I think that's a little bit kind of funky and off, although we don't practice that way, is that some Medicare Type B plans will only cover vaccination if you're at medium or high risk, but most of the plans now are covering it regardless. And I think that's really going to change with the new CDC recommendations. But there's a little bit of a lag, I think, with the federal government as far as trying to get caught up with that. But when it comes to local coverage, we cover 100% no prior authorization. Of course, therapy is a different story that does require prior authorization, mainly because of the costs, because it's around $11,000 to $12,000 for treatment costs, depending on which protocol you use. I think the wonderful thing, especially being from the pediatric end, is you basically can say now that anybody under the age of 60 should be immunized or screened out, depending on their exposure or what have you. And so it's now uniform. And we're not really seeing very much because all in the pediatric realm, because all women who deliver get screened pretty much for Hep B and now Hep C. So I put a big push out for that. It's a uniform recommendation as well. But most of the children that I've seen have either been immigrants from high-risk areas, either Southeast Asia, or adopted children from Eastern Europe. It's another big group that I used to see in California. Perinatal transmission, and then teenagers who are doing IV drug abuse and things like that.
Thanks, Dr. Haight, and thank you both for joining us today. I'll note for folks who joined us a little bit later that we were already having a robust discussion even before we started recording today. So I think there was going to be a lot more to talk about. So I'll open this up to both of you again, and this is a broad question, but what are some of the challenges you foresee around implementation of this new recommendation about getting adults vaccinated for hepatitis B? So I'll start with you, Dr. Yamada, if you want to throw your thoughts in the ring.
Yeah, so I would say that you know, if we have a patient population that you know, that for whom we are responsible, I suppose that it'll be good to see you know, in the way that screening for hepatitis C is routine and HIV is routine. Hopefully, screening for Hep B will become routine as well. And then you know, the way in which we are encouraging, you know, basically everybody on the age base to get pneumococcal vaccines or varicella zoster vaccines. You know, that in the way that those have become routine, it'll be nice to watch hepatitis B become routine in that way. Another task for Desiree, our clinic manager, who is also on this call, to remind our residents at our residency clinic to be offering those sorts of things, I suppose. But again, as far as the Hep B goes, I think you know, we also do want to, like I said, make sure that we catch people that actually have hepatitis B, and you know, as Dr. Huang mentioned, you know, we do want to obtain records of previous vaccination, but as I was discussing a little earlier with Des today, it's really quite hard to obtain vaccine information in like the new patient who comes as an adult to your clinic because they probably got hepatitis. You know, if they're under 30 years old, 31 years old, since universal vaccination of newborns started in 1991. They should have gotten the vaccine. And in Hawaii, we had a pretty robust catch-up vaccination program. Around 1995, the Department of Health started doing vaccination of catch-up vaccination of 11 to 12-year-olds. And it was in the schools, so it was sort of a mass vaccination program. So, you know, it kind of means that in Hawaii, at least, if you're under 38 years old, you should have been offered a hepatitis B vaccine. Now, getting those records, you know, 10, 20 years later, when you're no longer with your pediatrician, is a challenge. You know, there is a Hawaiʻi Immunization registry that's connected with our electronic health records. You know, we at the residency have Epic. It's a pretty decent EHR in terms of being able to connect with various organizations and such. I think you know, including Hawaiʻi Immunization Registry, but Hawaiʻi Immunization Registry also has been down for the past couple of years. I think that it was all hands on deck for COVID for the past couple of years. So nobody was paying attention to that at Department of Health, I guess. So there are also these sorts of challenges, I think, in terms of saying that you know, we're going to institute universal vaccination of adults, you know, to figure out who has actually received what in the past.
Thank you, Dr. Yamada. And definitely, that issue with documentation is something we see for all vaccinations. And you're also correct, the Hawaiʻi Immunization Registry wasn't available for many years. And I think it's just restarting with COVID with that as the priority. So definitely some of the challenges we're going to have to deal with as we try to increase adult immunizations for hepatitis B. Dr. Haight, do you have anything else you wanted to add to some of the?
Well, I think one of the interesting things, there was an article recently from Kaiser study of about 30,000 adults that got 2 versus the 3 vaccine series. And the encouraging thing there was, at least in their study, is the group that got 3 doses only had 26% actually get all 3 doses.
Oh.
Versus with the 2-dose regimen, they got upwards of 45%, so almost double. Now, granted, that's probably going to be, I think, a little bit on the low side is what I would think, but it depends again on the social determinants of health and what population you have. But I think this is a really important concept to think about, especially on our high risk houseless patients, the ones that really have a lot of behavioral health issues. Even if you can just get 1 in, that's better than none. And I think 1 out of 2 is better than 1 out of 3. So I think that's something that we all should be considering of what vaccine we're actually giving. And if it's a lower social determinant health group and all you have is 3, you're probably going to be okay. But in that higher risk group, I think you really should start to consider them to be a priority for getting the 2-dose regimen. I don't know how you feel, Dr. Huang.
Yeah, absolutely. Dr. Mike, really appreciate you bringing up that Kaiser Permanente study. And so, yes, it was looking at across 8 family medicine clinics and looking at comparing Endrix to Heplisav. And you're pretty on the mark with that article. And so we know, I think, not just with hepatitis B vaccine series, but with COVID, with any other series, when you can actually decrease the dosage in a vaccine series, you get higher completion rates. And so 2 doses really are better than 3 doses. And so really appreciate you bringing up that particular study. Thank you for highlighting that.
I think the other thing I wanted to bring up is if on some of the ones where you have to do the repeat series, some people are advocating doing double the dose, and they have shown markedly higher titers on double dose for the second time versus the first time. I think some of the more sort of side effects of pain at the injection site and things like that are a little bit higher, but that's another thing to kind of consider in higher risk patients. And I think that's where using some of the older CDC risk factors to decide whether or not you should be doing higher versus the high dose versus the low dose or normal dose, I think should come into play. So if somebody has little or no risk factors, maybe the regular dose should be the way to go. There's not been guidance on that, but that's just sort of my impression. I don't know how you feel, Vivian, on that.
Yeah, I think there is no guidance on that, but would you mind clarifying when you say double dose, you're talking about the traditional 3-dose, is that correct?
Correct. The traditional 3-dose where they upped the dose, and the titers went from 52 to 72% at the end compared to the low dose versus the high dose.
And so, this is in a generally healthy population, is that?
That's correct.
Yeah.
So it's again something to consider that there are maybe some other options in I think in higher risk populations, that if you really want to push those titers higher and you need to for some reason, say somebody is going to go on hemodialysis as an example, you might want to push that before they either go on hemodialysis, or if they have other immunosuppressive drugs, like they're on hemo because of lupus and they're immunosuppressed and things like that.
Yeah, I will comment that there are quite a few published studies already looking at particular groups that are immunosuppressed, particularly HIV groups, that when you actually, if they haven't responded before to the traditional 3-dose series, we've seen some favorable results with the 2-dose Heplisab. And I'm certainly happy to provide any more information if anybody on this call is interested in that. But there's been 5 studies really looking at this, in particular immunocompromised persons. And so I'll just comment that for the traditional 3-dose series, the adjuvant is actually aluminum, which is an older adjuvant. And so in Heplisab, there's actually an adjuvant, the CpG 1018, which is considered a newer adjuvant, and actually it's a toll-like receptor pathway that it uses, and it's actually a more specific and a more robust immune response that it elicits. So that's the difference between the traditional 3-dose series that we've had, for the last 40 years, as compared to the 2-dose series. So yeah, great comments, Mike. Thank you.
Thank you so much, everyone. And I just note that I think some of Dan Saltman's questions were answered, but I'll read them out loud quickly, just so that we can assure folks who are just listening in know. So Dan had asked just about the percentage of vaccine recipients who are shown to be non-respondents after the second series. And Vivian, thank you for responding to that. You had noted that it's about 5 to 10% are non-responders to hepatitis B vaccines after 2 series. So for those who are just listening, just wanted to make sure you had that opportunity. Dan did also ask that it used to be the double dose, that higher dose that you were just referring to was recommended for hemodialysis patients. And he just wanted to clarify, is that still the recommendation? And I think you just said that, but is that still correct?
Yeah, that is still correct. If you look at the MMWR table, it is actually double dose for Endrix and Recombavax. Now, I will just comment for hemodialysis patients, there actually are 2 actually published studies also looking at Heplisab. I will say that that's not an on-label indication. So, but there are these published studies that are available. And so, Dan, I'm happy to reach out to you and provide that information to you after this presentation.
Good job, Huang. And I know I just, folks have other comments and questions, please put them in the chat and we'll make sure to address them. In the meantime, I did get a question for, I think, all of you folks. When we're talking about access, Seiji, you were talking about certain communities. Mike, you also mentioned, folks also who might have social determinants of health that disparately impact them. So someone asked about if you folks can foresee challenges for our rural communities, since a lot of our work is usually very Honolulu centric, it's very urban, but to consider all of our neighbor islands, of course, and also our rural communities outside of Honolulu. So if you folks want to comment on that.
I can comment at least on living on Kauai, being not non-urban. It's just a personal bias, is I'm really excited about the 2-dose regimen, because I think that that's going to be the answer for these folks who have a hard time getting back to clinic and getting back in time to get that dosing. 3 doses is really, really hard. Personally, I got 3 doses back in the 80s when I was a resident, and that was hard. I can remember trying to squeeze that in on my own schedule and everything else. But for a lot of folks who are working or have transportation issues or what have you, I think ideally I'd like to see a 1-dose regimen, but right now I'll take a 2-dose over a 3 doses. That's my feeling.
And Dr. Yamada?
Well, you know, I'm the very remote medical director of the Lanai Community Health Center. I think we do a pretty good job there in terms of paying attention to vaccines. There's some challenges, of course, with vaccine hesitancy, you know, with regard to COVID vaccine or influenza vaccine in particular. But yeah, we'll see how it goes with Hep B. I don't think there's been very much resistance, you know, to Hep B vaccination of infants in particular. You know, when it's due for infants. But I do want to ask Dr. Mike, is, you know, when MMWR or the Acip says you know, Hep B Hep B vaccine is recommended, does that sort of mean that insurance companies in general need to cover it? And because I think I've actually tried ordering the 2-dose and found that it was not covered by particular insurance. I don't remember which one it was.
Yeah, some of the thing on the, as you know, the 2-dose thing has a different code. Being very technical, it has a different request code. And so I know initially a number of different plans made the code non-covered or PA, prior authorization. But more and more are transitioning that into, you know, it's no prior auth needed. But I think that's where some of the delay comes in on the insurance end of things. Like anything that I see, because I do a lot of review of things like this, I think if you justify it, and you might have to do a PA with it, a prior auth with it to get it covered. But that's usually, if you're going to be doing that, that usually means they're going to have 3 visits then, because you're going to see them and then you're going to do the prior auth and then they're going to have to come back 2 times for the shot. I think that's kind of dumb. So I think that's a challenge that the insurance industry really has. I think part of the thing too I was surprised on the Medicare B plans only doing it for medium or high risk. I really feel that that's got to change with time, especially given the new recommendations.
So my understanding is that that for Heplisav, it should be actually a Medicare Part B as in boy. I certainly hear you, Dr. Mike. The Medicare Part D as in dog is actually, I think we ran into lots of issues with Shingrix, with Zostavax with that. And so certainly can echo that sentiment. And I will just say here, I agree with you for rural populations, 2 doses is certainly favorable to 3 doses. And we'll just actually highlight here that Heplisav is a 2-dose over 1 month, right? So it's pretty easy if you get that patient in at time 0, and then 4 weeks later, you could probably schedule it in your EMR and get them back in. It's that 3rd dose that's 6 months away that's kind of harder. And I know that in some EMRs, it's actually challenging to actually schedule your patients out 6 months after the fact. And I will just say that when I was working on the Navajo reservation, pretty much a lot of my patients still didn't have cars, really rural, still patients had no clean running water or electricity, really challenging to get them back in. I wouldn't know when would be the next time I would see them. And so the 2-dose option, again, is I think a better option when you're looking at getting your patients fully vaccinated. So completely agree with your statements there.
Thank you, Dr. Wang, and thank you, Dr. Haight and Dr. Yamada. Just like last time when we had this session, we're running up right to the edge. So we appreciate folks. It is 1 o'clock Hawaii time. I'm so sorry. Dr. Selman, I do see your hand raised, but feel free to reach out to me and I can connect you with these folks for a follow-up question.
Well, it's an important point, that is. Please let me make a quick point about it.
Please make it quick, Dr. Selman.
Quick point. I've worked, like Dr. Yamada, I've worked in under-resourced places, and that my understanding is that even from the old Hep B vaccines, that there's, you know, that the first dose gives you a kind of 30% response, and the second dose gives you up to about an 85% response on the 3-dose series. And then that's the third dose takes you from, from 80 or 85 to the 90 to 95%. So I see Vivian shaking her head, but two doses of an old vaccine is better than no doses of any vaccine. That's kind of my point.
Well,
Dr.
so
Huang,
Dan,
sorry, really
so
quick, I just,
may I
I'll
make
let you, yeah, I'll let you finish, Dr. I just want to note for folks who have to leave, we just want to thank you for your time, and we will be sending a recording. So if you miss this, just note that the response will be recorded. So thanks for those who have to go. Dr. Huang, if you want to respond to that, go ahead.
Yeah, so Dan, I think you make a really good point, and I'm actually right now studying for my tenure research for internal medicine, and so I think the misconception here is that after 2 doses it's sufficient for the 3-dose series. What I'll say is that those studies were done 40 years ago, where the prevalence of obesity and diabetes were a lot less, and so what we're seeing now is that we've got more Americans. Unfortunately, there's more obesity, there's more diabetes, and the traditional 3-dose series just doesn't elicit that kind of a response. And so I'm happy to connect with you to share some of our pivotal trial data. And then there's also a recent vaccine that also came out that also again looked at Engerix in this way. And so 40 years ago, I think, that was the thinking, is that, after 2 doses, it's sufficient, but it clearly isn't the case anymore. And so just want to make sure that we look at it in real time. And so we just know that, as I think many folks on here know, that the immune response is really dampened in persons that have higher BMIs and also persons with diabetes. So I just wanted to comment on that. So thank you, Dan. It's a very important point, and I agree with you that back then that's what was good. But I think we've got other fish that we have to fry now and other battles to fight. So just wanted to make that comment.
Thank you, Dan, and thank you, Vivian. And speaking of fish to fry, I know a lot of folks are heading to their lunch right now. So thanks for everyone for joining us. I want to thank all the folks who provided comment. Again, thank you, Dr. Yamada, Dr. Haight, and Dr. Huang for robust discussion. And we will see you folks on our next session. So we'll let everyone know whenever that is. Stay tuned. We'll send out a copy of the slides as well as a recording. Please enjoy whatever fish you have to fry, and we will see you folks next time. Aloha, everybody. Take care.
Aloha. Thank you all for being here. Good meeting you all.
Yeah.
Thank you.
Take care.
Bye.
Great discussion.
Great.